ABG interpretation, case study, Aglan protocol. How to study ABG? 4 items. Number 1, listen carefully to the clinical history. Number 2, study the lab investigations, including the ABG chart. Number 3, look at this Aglan ABG table to fill in the spaces measured and calculated. Number 4, back to this Aglan ABG table to study pH, chloride items, bicarbonate items, oxygenation state of the lung, and ventilation state of the lung. Clinical history. Study of the clinical history will be important for 2 things. Number 1, to anticipate the pathophysiology. Number 2, to anticipate the sequelae of events. Anticipation of the pathophysiology, like what? If the patient is vomiting, is going to lose chloride, gain bicarbonate, to develop hypochloremic metabolic alkalosis. If the patient develops diarrhea, will lose bicarbonate, gain chloride, to develop hyperchloremic metabolic acidosis. If the patient develops diabetic ketoacidosis, bicarbonate will be consumed, so he will develop high anion gap metabolic acidosis. In a renal failure patient, bicarbonate will be consumed by the fixed acids to develop also high anion gap metabolic acidosis. Methyl intoxication will be associated with the formation of formic acid to consume bicarbonate to develop high anion gap metabolic acidosis. Stable congestive heart failure, the patient will have hyponatremia, maybe on diuretics like furosemide to develop hypokalemic metabolic alkalosis. Liver cirrhosis patient will have hyponatremia, hypoalbuminemia, hypokalemia, and develop metabolic alkalosis. Anticipation of the sequelae of events, like what? If the patient develops vomiting, then became shocked, vomiting will develop hypochloremic metabolic alkalosis, then shock will develop high anion gap metabolic acidosis. Lab investigations, you should study sodium, chloride, potassium, BUN, serum creatinine, random blood sugar, ketone bodies, and serum lactate. Then come to the ABG chart to study it, to see the values. For the calculations of the calculated items, don't forget these formulas, these equations. I collected it in the form of golden rule in these 4 slides. You should know it by heart. Number 3, look at the Aglan table and fill the spaces. These spaces are 2. Number 1, the measured items will be taken from the lab investigation and the ABG chart. Then the calculated items with these red arrows, you have to calculate it before starting the Aglan ABG table. Number 4, study Aglan table. This Aglan table, as I have mentioned before, is formed of measured values and calculated values. To start with, number 1, by the pH. Number 2, the chloride items. Chloride items, serum chloride, chloride sodium ratio, corrected bicarbonate, and strong ion difference. Number 3, bicarbonate items, serum bicarbonate, anion gap, buffer base, strong ion gap, base excess. Number 4, oxygenation state of the lung, FiO2, BO2, B arterial oxygen, partial pressure of oxygen of arterial oxygen, and alveolar arterial gradient. Number 5, ventilation state, the partial pressure of carbon dioxide and its relation to the pH and bicarbonate. To study the pH, for sure, see whether is it normal, acidemia, or alkalemia. Start studying the chloride atoms. Number 2, as I've mentioned before, serum chloride, chloride sodium ratio, anion gap, strong ion differences, and corrected bicarbonate. From these items and from these data, you will come to the diagnosis of the start diagnosis, start pathology, the first pathology. Number 3, studying bicarbonate items, serum bicarbonate, buffer base, phase excess, strong ion gap, and anion gap. This will give you the last or the second pathology and the second diagnosis. Number 4, the oxygenation state of the lung will be studied through studying FiO2 and BaO2, and you will come to the formula alveolar arterial gradient to diagnose the oxygenation state. Is it normal or hypoxic? Number 5, studying the ventilation state through studying the partial pressure of carbon dioxide correlated with bicarbonate and pH. See whether the patient is hypoventilated, hyperventilated, normoventilated, compensated, or not. Case number 3, a 44-year-old moderately dehydrated man was admitted with a 2-day history of acute severe diarrhea. Blood pressure 80/60. From this history, we can define 2 pathology. Number 1, diarrhea followed by shock. These are the lab data. pH 7.31, partial pressure of carbon dioxide 3, partial pressure of oxygen is 93, bicarbonate 16, sodium 144, potassium 2.9, chloride 110, PUN 31, serum creatinine 1.5. Let's come and study this Aglan table. Number 1, the pH. pH is 7.31, it's acidemia. Low bicarbonate, so this is a metabolic. And at the same time, there is washout of carbon dioxide compensatory, so there is a compensatory washout of carbon dioxide. If you calculate the ratio between the two, you'll find that it's true compensatory. Then we come to the second item, chloride. Chloride, this is serum chloride is 110. It's high. If you come to chloride to the sodium, more than 74. So there is some sort of hyperchloremia. Yes, it's diarrhea. Hyperchloremia. Strong ion differences is less than 40. It is 32. So this is a hyperchloremic metabolic acidosis. What about the corrected bicarbonate or the bicarbonate during this state? Corrected bicarbonate was 20, less than normal. So this patient developed diarrhea with loss of bicarbonate, gain of chloride, so he developed a hyperchloremic metabolic acidosis. Then he developed shock, and this shock, the bicarbonate dropped from 20 to 16, so there is loss of more bicarbonate with an anion gap, high anion gap. And this drop in bicarbonate, you can see it in the decrease in the buffer base, and the base excess, there is severe base deficit. From these data, you'll find that this patient developed 2 things. Number 1, hyperchloremic metabolic acidosis due to diarrhea, followed by high anion gap metabolic acidosis due to shock. When you come to the oxidation state, it was on FiO2, room air, alveolar or calculated alveolar pressure of oxygen 100, the measured pressure of oxygen arterial 93, alveolar gradient 7, this is normal oxygen state. As for the carbon dioxide, when you come to correlate between the bicarbonate and the washout of carbon dioxide, it is true. So this is a compensatory washout of carbon dioxide. So this patient developed that. First, due to diarrhea, hyperchronic metabolic acidosis with normal NN-GAD, to be followed by high NN-GAD metabolic acidosis with normal respiration and normal oxygen state and normal ventilation state. Thank you.